Hi, my name is Braden Kuo. I'm the director for the Center for Neurointestinal Health at Massachusetts General Hospital in Boston, Massachusetts.
Hi, my name is Dr. Kyle Stoller, and I am the director of the GI Motility Laboratory at Massachusetts General Hospital, also in Boston, Massachusetts.
Hello, I'm David Kunkel. I'm a gastroenterologist and motility specialist at the University of California, San Diego.
Well, hey, thank you a lot for coming by and talking. I mean, we're going to talk about a few different topics, but let's dig in and talk about gastroparesis. I know I spent a lot of time thinking about gastroparesis, and I was involved in the ACG guidelines for that in 2022. But there's a new set of guidelines coming out from the AGA, still under draft document review, but there's quite a bit of thought about this guideline.
Thought is a nice way to say it.
Yeah.
Maybe controversy.
Let's dig right into it. So, Kyle, you were an author on this AGA guidelines. Can you tell us sort of the process of how it happened, how it might be similar or different to the previous guidelines or previous sort of recommendations out there? And then after that, maybe we might think about how to go over some of these recommendations and how we might put that in perspective.
Sure. Thanks for giving me the opportunity to talk about the guidelines, because I do think that the guidelines in some ways are misunderstood because they have a very strict, sometimes someone might say overly strict, but a strict methodology. And I think the public and gastroenterologists at large don't necessarily understand how guidelines are created through the AGA process. So in this case, the AGA governing board decides that gastroparesis is a topic that they'd like to cover, comes down through the guidelines committee on which I was serving, and hence my involvement. And then we solicit several experts in the field, in this case, Henry Parkman and Michael Camilleri, who both really need no introduction. And then in conjunction with other guideline panel members, we really start a very rigorous process where we look through the literature at large, including abstracts and PubMed, published papers, unpublished data. We'll solicit information from the authors if we haven't gotten it. And we'll decide a priority. What is our most valuable population here, right? What is the population that we'd like to examine? What are the questions that we would like to look at? And then the methodology is fairly standard. So in this case, the question is we want to look at patients with gastroparesis as defined by gastric scintigraphy. We want to define first, how would we ideally define gastroparesis? And then using a very standard approach using the GCSI, which is the gastroparesis cardinal symptom index, as to what is the minimally important difference threshold that we think would meet muster. And then we're going to use that muster, that sort of standard that we've applied, to actually go through the data that's out there. And so then after this very rigorous data review, this will sort of go into a meta-analysis, and we'll extract data from its various forms and report, do the various trials on the various drugs out there meet the standard? And I'll say up front, right, the controversy here, and there's been quite a bit of controversy, I think it's open, right, I think it's worth mentioning, has been that really there weren't a lot of drugs, therapies out there that met the level of recommendation. And the two drugs were metoclopramide, which of course is a very old agent that's been used for years, the only FDA-approved agent, and then erythromycin, which some gastroenterologists would argue doesn't really have a place in the modern gastroparesis management. So I think the controversy there has really been that we're really only formally recommending two agents, and that's meeting the grade methodology level of evidence. But I think we can talk more about some of the nuances of how this came about.
I mean, tell me a little bit about your thoughts before I go into asking a little bit about even what is strength and all the different types of designations mean, and how does a clinician even interpret that sort of information? But first.
Yeah, Brad, these draft guidelines, once finalized, will have very real implications on my clinical practice managing gastroparesis patients. And let me sort of articulate that in, I think, ways that are easy to understand. Kyle mentioned one of the therapeutics that did meet this threshold, pass muster for efficacy, is a drug called erythromycin, which is an antibiotic. The patients that I see are worried about side effects. Long-term antibiotics carry side effects. And
I mind you, that recommendation is based on strength, is conditional. And it's worth trying to understand what that means with the strength of evidence as being very low. So, I mean, it sounds very daunting that it's barely even a lukewarm support for this.
It's lukewarm support. but it's mentioned. And, there are concerns with that drug, tachyphylaxis. It might, not maintain its efficacy after a couple weeks of use. With that being said, our gastroparesis patients are very sick. They can present to urgent care, emergency department. And if I haven't had a discussion with that patient and captured that in their clinical note about this medication as an option, then I'm in trouble. So once this guideline is finalized, I'm always with my gastroparesis patients going to be cognizant. Have I reviewed this treatment, which has this conditional recommendation based on the guideline? Conversely, a medication like aprepitant, which is approved for chemotherapy-induced nausea and vomiting, historically, I would say, well, the aprepitant for relief of nausea, the APRIN trial supports its use in gastroparesis. This guideline, if finalized, has said that doesn't meet the threshold of efficacy. So I'm not going to be using aprepitant for gastroparesis in these patients. I'm going to need to stick with nausea that could be related to a chemotherapy class medication. So these are ways in which the guideline would impact my practice.
I mean, that's intriguing. So, at one level, the way these guidelines are written, there's a top level box that talks about the strength. And if you go down these things, I have these right in front of me, the strength is all conditional or none. If you go through the strength of evidence, it's either low, very low, or knowledge gap. And this sounds really, really pessimistic. And maybe that is the state of our therapeutic options for gastroparesis, but can you put this in perspective for us, Kyle?
Yeah, I mean, I think in some ways the pessimism is warranted, right? I think the field has suffered from poor definition of who the participants are in clinical trials. And I think it's been difficult because all patients really need to have a gastric emptying study to qualify, and it can be harder to recruit for these trials. I think the way I would view this and the way the AGA would view this, and I hear David's point, I think it's well taken, and I think it's a point that's shared by a lot of people who see patients with gastroparesis, is that this is a snapshot of the evidence at a given moment, right? And what that means is that, according to a given methodology, and the methodology doesn't change, right? So it doesn't matter if you say, well, gastroparesis is an underappreciated, patients suffer maybe disproportionately. I think we would all agree on that, taking care of these patients. It's sort of saying, if we hold a certain standard, this is what the evidence is out there. And so you can imagine for well-funded areas like inflammatory bowel disease, right, there's going to be a lot more recommendations that are strong or at least, we recommend for. With gastroparesis, when there's been a lot of heterogeneity in trials and a lot of the data for these drugs that we were talking about where there is a recommendation are from many, many years ago, it's going to be more difficult. So what I would say is that if you read below the recommendation, right, that says we suggest, let's say, against the use of aprepitant, for example, then there are sort of what I would call the clinical pearls. And all of those who are experts in the guideline all agree that for many of these agents that we listed and we say we do not, we suggest against, what that really means is that there is not a level of evidence that supports its use, right? I mean, even the APRIN trial, right? You wouldn't reach the threshold for evidence even within that trial, let alone when you extrapolate to the meta-analysis. But many of us would use these agents in a shared decision-making model, meaning in a patient who values relief in nausea and is willing to accept potential cost as an issue for, let's say, aprepitant, or potential risk of side effects, let's say, for some of the surgical invasive type treatments, that this would be something where you would actually have a conversation and do shared decision-making. So I think that's the nuance that's often missed. But that said, I'll be the first to acknowledge that if you read this without a very nuanced understanding of grade methodology, which I admit I didn't have until I became part of this process, you would come away saying, well, we're not really recommending anything for this patient population that really is suffering. So to me, I sort of say this as a call to action. I see this as to say, and these are not intended to be insurance recommendations, although I'm sure in some extents, in past experience, the AGA has not seen an effect on insurance approvals. But at some point, it's going to play a role in some decisions that we're going to face when we want to access these therapies for our patients. But this really is a call to action to say we need to do more to this field. We need to better define it. We need to come up with more agents. We need to offer our patients better options, because the options that we have, although certainly they benefit some populations of patients, right? Maybe not at a clinical trial threshold, we're not seeing that kind of level of data and level of evidence that we really need to help a bigger chunk of this population.
There have been different documents put forth. HCG had their own guidelines, of which I was an author. There have been opinion pieces, key opinion leader pieces on sort of state of thought. And then this version, which I must say, I think it's the strictest methodologically interpretation of the data. And while I applaud the approach to some degree, I think the devil's in the details. And I think that other guidelines have given a little bit more latitude in terms of giving practical guidance through nuance buried within the overall recommendations. And the concern here is that the recommendations sit above, and then a lot of people may not spend the time to look in the lower box for the details. I'm curious, how do you think that's going to play out? And do you think the lower box of the nuances is enough, or is there more work that we could do to deal with this?
Yeah, I think you're right on point with that, Brad. The key here is this threshold that was set. And this threshold was picked, and then the data was analyzed. And if you change what that threshold is, then you get a whole different output. And so that's the challenge. If you make the threshold so big that almost nothing can achieve that, have we helped patients? Have we helped physicians and allied health professionals? I'm not sure. I know that Kyle and his colleagues are doing their very best and approaching this with scientific rigor, and they thought critically about this. But therein lies the problem of trying to handle imperfect data and trying to set a standard with this, these symptom indexes that have been used for gastroparesis. And it's why here in the US, we have fewer therapies than, people elsewhere in the world. This is a factor.
So in other words, it may be that we all agree that the state of literature may not be enough to be giving a more optimistic viewpoint, and that could be a call of action, but still may have significant reverberation in terms of the impacts. So I thought that was very fruitful. Do you guys have any final comments about this topic? Because I know this is still churning and churning in terms of people's minds.
Yeah, I think, again, this is sort of a snapshot of the science. The threshold, to speak to David's point, was actually chosen as a more liberal threshold in that it was the 0.5 versus 1 on this GCSI, which is a measure of symptom severity for gastroparesis. And the importance of doing it ahead of time was that we couldn't look at what came out and then choose our favorite therapies, right? Because there's potential for conflict of interest. And I think one of the most robust parts of these guidelines is that they are much less susceptible to conflict of interest, right? If you ask me, how do I treat gastroparesis? I'm going to talk about my anecdotal experience with many of these drugs that we don't recommend during these guidelines that have done amazing things for patients, right? And therapies, including GPOM, et cetera. But, we're not holding an objective lens to it, right? So, I think at the end of the day, we all agree we want to offer the most things to our patients. Many of us are seeing patients who are refractory to many of the treatments that are recommended in the guidelines, right? And that's where we sort of feel that rub. But with an objective lens, the data is what it is, and it's less susceptible than any sort of expert opinion, consensus document to conflict of interest, both commercial, but also just our own biases from being practicing clinicians. Now, that said, the caveat, which I would fully acknowledge, is that gastroparesis is a field which may not necessarily be ready for grade methodology. That is a reasonable critique. But I think, again, for me, it's more of a call to action that we need to better characterize this patient population and continue to put efforts toward funding and research in this patient population.
So the field may not be ready. What do you have to say for that?
This is a disorder that primarily affects women. This is a disorder that involves everyday symptoms. The burden of disease is profound in scope and scale. And so I agree, this is a call to action, and that the field hasn't been ready reflects poorly on us. And we need to do better for our patients and the people in their orbits who are suffering. And so I agree with that being sort of the upshot. We need to do better on the provider and investigator side.
So really, it might be that It's not that this should be limiting. This should be really a fire under our belly to sort of invest more energy, efforts, resources into trying to do better by this disease and the patients that are suffering from this.
Yeah, and I think the investigators need to come together and realize that their field is in some degrees in peril, and that they need, consensus is better than sort of everyone holding out in their own camps. And I think separately, I think the FDA has to realize that this field is going to need maybe a little bit of more lenient standards for the approval of agents, because I think some of the bar that are being set and upon which the trials were based and designed may not really be adequate for this particular disease.
So that was a lot of healthy discussion about gastroparesis. Let's switch to another topic. New pharmacological agents and acid suppression, PCABs. It certainly had some experience in other parts of the world, particularly Asia, and it has now come to America with at least one therapy being FDA approved. Opportunities include it's how it might shape gastroesophageal reflux disease treatment as well as H. pylori treatment. So let's first talk about gastroesophageal reflux disease. I mean, PPIs have been around for a long time. There are still many people that suffer from reflux-like symptoms. But with this new agent, I mean, what's been your experience of putting these into action?
Yeah, so reflux being one of the most common symptoms that we see, right up there with functional dyspepsia. For me, it's felt like I've had a really big closet, but instead of having different types of clothing, it's just been filled with winter coats. And I'm in San Diego. We don't really need winter coats. It's nice to have a t-shirt every now and then. And so finally, we have this new class of medication, potassium-competitive acid blockers. And so that's exciting and very easy to start using because our patients have been in these winter jackets for so long. Not everyone is comfortable in a winter jacket. And so it's great to have a totally different medication, works differently and has important differences, and to just try that out for patients who've been suffering with this fairly common symptom complex.
I do find that analogy that you say interesting and that you're from San Diego. I would have thought that you had a closet full of T-shirts. And then now the patients that are suffering more feel like T-shirts are not enough to deal with the weather outside. So maybe they need a winter coat here. So maybe from that perspective, like new kid on the block, but how do you really use it in your mind?
Yeah, I mean, I think we need to be cognizant that it's a new kid on the block. And of course, any new kid on the block comes with higher costs, right? And that's something that could be passed on to payers or to patients. It's something we should think about. And I think the data would suggest, at least relative to one of the PPIs, that it's not necessarily superior, at least in terms of certain outcomes. I think the key here, though, is that I think it's all worth talking a little refresher about how proton pump inhibitors, right, which is the winter coats that David's been using for a long time. T-shirts. How do they work, right? They need to be taken on an empty stomach, pass through the stomach, go into the duodenum, get absorbed into the bloodstream, work their way back to the bloodstream to the parietal cell where they bind to the proton pump. And then you have to eat within 20 to 30 minutes to activate then that proton pump. And so, you can imagine that pharmacology has been very difficult for many of our patients to deal with, especially on those people who need that twice daily dosing and really would benefit from an evening dose because they have nighttime reflux. So for me, it may be a little bit less about efficacy. I think there's more data to come. And it's more about the practicality that, how hard is it to take a medication twice a day, and let alone twice a day, but one where you have to time it relative to meals. And so to me, the advantage is we can treat more patients better because these patients have less restrictions, right? The drug works faster. It reaches a steady state of acid suppression in a faster way. And there's less dips than what we see with the proton pump inhibitors. So while I might not say that we have the data to say that it's lo and behold, much more effective, efficacy is not just about does it work in a clinical trial setting, but does your patient actually take it? And in that case, I think these drugs are really going to win because they have much less qualifications, much less noise around how to take them compared to our existing agents.
I mean, it's a very good point. I guess I would say that much of the indications for proton pump inhibitors doesn't necessarily need the maximal effect. I mean, all the things you're talking about are great. I mean, I think they're squeezing every last efficacy of that PPI. But I would argue that many conditions don't need 100% effectiveness of that PPI to do their job, whether it's peptic ulcer disease or even mild to moderate gastroesophageal reflux disease. And so how does that weigh in for you in terms of how you put that in perspective? And so we've talked about how it could be new and great, but who do you really use it in right now?
Yeah, I think, right now I have this big population of patients who've had inadequate symptom control with proton pump inhibitors. So that's sort of the low-hanging fruit to try them on a new agent that works differently. And, to build on Kyle's point, the proton pump inhibitor, when you swallow it, is an inactive prodrug. And so it needs acid to get turned on. So one of the ironies of proton pump inhibitors is that they need acid to block acid. And so eating is a social activity. We gather around a table just like this and we eat, and it's not always scheduled. Sometimes it's impromptu. And so this plays into some of the challenges, the practicalities that Kyle was referencing. And so, that could be a factor why some patients aren't getting adequate symptom relief. I appreciate your point though, Brad, which is not everyone needs 100% acid blockade. They don't need a pH to rise to 7. But that ease of use, relieving that pressure of having to take it before a meal can make just life easier for these patients. And we all know that symptoms are complex, have a lot of different factors contributing to them. And so if we can make our patients' lives easier, that's an advantage for a PCAB.
I hear about ease and advantage, but I'm going to push it one further. I mean, you're suggesting that if PPIs don't work, you can try PCABs in hopes of getting better efficacy and better quality of life in terms of taking it. But how do you really know that acid is the problem? And so another way of looking at it is if they fail to respond to PPIs, they should undergo pH testing and then see if it's truly really acid and whether you should be bothering even getting a better weapon for that versus thinking about something else. So, I mean, how does that play into determining whether they have truly acid reflux escape or visceral hypersensitivity that's contributing to patients' symptoms?
I'm a big fan of pH-metry reflex testing early on to help select which patients indeed have true acid reflux. Because otherwise you have someone drowning in a river and you keep throwing them a fire extinguisher, that's not helping them. They need a buoy, a different kind of treatment. And so, point taken, we should really sort of prove that these patients have true gastroesophageal acid-driven reflux disease early on. And then within that group, if they're not having adequate symptom relief, then you can explore these different therapeutic modalities.
Yeah, I think that your point is well taken, that a lot of these patients who are not doing well on proton pump inhibitors, in fact, acid reflux is not the issue, right? It's visceral hypersensitivity, it's functional heartburn. And for those patients, a PCAB is not going to be the magic bullet. I don't have the beautiful metaphors that my colleague David has, which I've really been enjoying during this podcast, a fire extinguisher and you're drowning.
T-shirts
and winter coats. I think separately, there's a larger population here that we're not talking about the people with proven esophagitis, right? I think pH testing is great, but I think for many in the community, there's still some barriers to getting that. And so PCABs could be a first-line agent before you send someone to the big city academic center to get testing.
Or before you get an invasive, uncomfortable pH probe down your nose?
Correct. I think the other population where I think there could be a niche here are these on-demand reflux people, right? More and more, we're hearing about the side effects of proton pump inhibitors, and I don't think PCABs are going to be necessarily better from that perspective, right? I think it's very similar in terms of what the potential risks are. But for many patients, right, they don't need a continuous PPI, right? They may have flares of symptoms for a couple of weeks at a time, maybe every couple of months, maybe once a month. And for those patients, right, they want to take something on demand for a week or two. And proton pump inhibitors, in order to reach that symptom control threshold, you're going to have to wait several cycles, right? 2 to 3 days. Whereas PCABs, you're actually going to get a very quick onset. And we all have had patients who said, oh yeah, I take PPI whenever I feel heartburn. And we were like, no, it doesn't work like that. So I think that's also where, again, this is about the practicalities, not necessarily the efficacy, because if we could plan ahead of time when we had flares, the PPIs would be perfect. They would do the same job. But if you're saying, you know what, I'm at a conference as I am today, I'm eating out, I'm eating late, I'm drinking red wine, I'm eating pasta, I'm going to take my PCABs for the next week here because suddenly I have the reflux. I don't want to wait a couple days for that benefit.
Well, I'm not sure. There is not on-demand data for PCABs right now, or is it in the works, or that's probably an area ripe for further investigation, right?
Yeah, ripe for investigation.
Great. Okay, last topic is H. pylori. I mean, H. pylori is still a worldwide problem. H. pylori has some unique ways it presents in the United States, probably because of different sanitary conditions. But still, it presents a problem. You can find it during endoscopy with biopsies. And now we have PCABs that can potentially change the therapeutic regimen. So I'm curious, what's your take? How has H. pylori treatment evolved in the U.S., and do PCABs make any difference in the treatment regimen?
Brad, I think PCABs are an important development because if you raise the pH, make it a less acidic environment, the stomach, the H. pylori take their clothes off and say, it's time to reproduce. And so H. pylori organisms really like a more neutral environment. And the antibiotics that we use kill bacteria when they're trying to reproduce. So efficacy, treatment efficacy, has a straight line with how acidic the stomach is, to what degree it's been neutralized. So if you have a therapy that's really good at neutralizing the acidity, you're going to be able to get those H. pylori organisms reproducing, get your antibiotics working better. So that's the idea that, PCABs, how they can enhance treatment efficacy for H. pylori.
I was waiting for some sort of morbidly provocative example of explaining that. But anyway, Kyle.
Yeah, I'm trying to get over the vision of the H. pylori taking their clothes off in the acid, but, I'll work on that. I think the important thing, for our listeners here is that the rates of clarithromycin resistance are rising rapidly, right? And so triple therapy, which we all cut our teeth on in fellowship, is really no longer appropriate in the vast majority of the United States. So that said, what do we have left, right? We have quadruple therapy, right? So we've already talked about how difficult it is to take a twice-a-day PPI. Now you're going to add in 3 other drugs, 2 of which have potential side effects for many people who take them. And you're going to give them to populations that many of which are coming from countries where English may not be their first language. And so you have a recipe for people who are not going to complete a full course or are not going to take a course correctly. So I think the real advantage, and I think as David eloquently said with the close-off analogy, is that, if you can control acid better, you can have a more simplistic regimen. And I think that benefits us all, because I think even explaining to a patient over the phone how quadruple therapy works and what they should do is difficult. And furthermore, tetracycline, which is an antibiotic that's really essential, is often not available or is very expensive. And so often doxycycline, a less effective substitute, is used. And so I think there really is a need for some more simplistic and more effective regimens. Whether that includes PCABs or not, I don't necessarily care, but PCABs are here and they are the ones that are providing that simplistic regimen as it stands.
Well, thank you very much. I've enjoyed all of this provocative metaphoric discussion. So thank you.
Thank you, Matt.
Thank you.
Thanks for having us.
Thank you.